saying that 45 minutes of the session will be dedicated towards peer review. But if we do finish earlier than that, then we will start Dr. Yousef's presentation early. So without further ado, I'm going to hand over to Dr. Kirti. Dr. Kirti, the floor is yours.
Thank you. Okay, so this was a 23-weeker, 2 days, born at 502 grams. At this point, this baby was 30 hours old, and baby got intubated at birth, given surfactant, then had been on a ventilator. So before this point, the pressure requirement on PCAC was coming down, and he was quite close to being able to extubate, given surfactant.
Yeah.
I think it's echoing.
Yeah. Now it won't.
Okay.
Yeah. Just muted somebody. Yeah.
And then at this point, when I did the lung ultrasound, the pressure requirement had increased. FiO2 was going up. So this was on the right side, the anterior, and this on the right lateral. I tried adjusting my gain, but I still have a lot of dropout here. I don't know why. So
if you'd just like to tell us which probe, which machine, what frequency you're using.
So this was a GE machine. No, sorry, Sonosite machine. And this is a linear probe. And the maximum frequency that I have is 9 Hertz on it. So that's what I use. And on this probe, I could see that there was no lung sliding. And for a baby who was 23 weeks, this is very good A lines, all these through. And this is, I think, the liver shadow, which is coming. The same thing over here, mainly just the A lines. And I'm not sure if we can call this as lung sliding, or is it just me, my probe? Because I feel there is some lung sliding here, isn't it?
Yes, I think so. And a really good approach in this situation, if you're confused about lung sliding, is putting M mode on. So, I mean, technically, the appearance of a seashore sign usually indicates that you have parietal over visceral pleura sliding over each other. But we'll wait till you finish so that Nadya can have a look at all the images, and then Nadya will come in. Yep.
So this was the M mode that I did at the right anterior region. And I think this is the barcode side. And this was on the left side. This is very clear pleural sliding, and I think these are subpleural consolidations, maybe. These are the A lines with some maybe B lines, but not very clear and not very compact B lines. I have a similar image for left lateral, but I wasn't in for today, so I haven't yet added that image. Yeah. This was the X-ray that we did, and this was the air leak. We did pull out the tube a little bit by 0.5, and we drained it by needle aspiration because after discussing with the consultants, it was felt the baby was too small, just 23 weeks, 500 grams. Putting in a chest drain might just destroy the whole chest. And once we had put the needle in, the baby recovered very quickly. The pressure requirements came down, FiO2 requirements came down.
Lovely. And did you manage to do a lung ultrasound after?
I did, and I could see the lung sliding. I haven't added those images here because I thought it would be tomorrow.
Okay, we'd love to see those images tomorrow. I'm gonna invite Nadya.
Thank you very much, Dr. Kirti, for sharing. The story is interesting. Going back to the questions I heard you asked was, well, going to the right anterior, which is on the left side of the screen. I totally agree with you. You're using a linear probe that goes up to 9 megahertz, which makes it difficult, of course, to get more resolution. But I think this looks really good. I was wondering if you're using any specific presets on your Sono site.
For this one, I used thyroid. It doesn't have a lung preset, and I tried entering the values myself, but it didn't allow me, so I had to use one of the presets.
Because going back to your question when it regarding the left lung, your question was, I feel there is something, but I'm not sure if it's the probe or if it's me, right? Is the lung sliding or not? And I agree. I don't know if you tried other presets than the thyroid, but it would be interesting to see with your sonar scanner. Sometimes the abdominal settings, neonatal abdominal could be really good. But if you go to the left lung, I agree with you. You have the feeling something is going on. It doesn't look the same way as a completely still right lung. If you go back again, please, to your first slide. When I keep looking at so this is a lovely stratosphere sign, but when we look over here, so you can't see my pointer, but I'm looking starting from the left side of the screen. I think when you look carefully at the pleural line, it's difficult really to say if they're sliding or not when it comes to the movement, although it looks different than the right one. So you have a difference. I totally agree with Dr. Alok that it would be interesting to see what you saw on the M mode here. But in addition, I mean, we're looking at the screen and we don't have the baby desaturating, so we have more time to look at this. I have the impression that you can see like tiny, like Z lines or something, meaning like tiny, tiny movements right underneath the pleural line, especially in the two on the other side. So more to the, yes, over here. At some points, there are some tiny little artifacts, and these can be giveaway signs saying that there is, at least that there's no pneumothorax, because you're seeing other stuff. I thought I saw it first, but now it's kind of choppy in the movements. But when I was looking at it, when you were talking about the case, I had the impression that there was a little bit. And if we move on, so further on, and the next slide, you have a very nice, so stratosphere sign, also called barcode sign. And then when we move on to the next one, here, of course, you're seeing a completely different vision. And I think that goes to show that even with the same probe and the same setting, when you move your hand a little bit, you can end up getting the answer you're looking for. My question to you regarding the right lung, the one where you diagnosed pneumothorax brilliantly, is where was the lung point? Do you find it?
The lung point?
The lung point.
No, because the whole of it, I couldn't see the sliding. And
Did you go? Yeah.
I tried to do the sweep like you had suggested last time to look, but this baby is so small and my probe is so big. It's a linear probe. So
or maybe it was a completely collapsed lung, so there was absolutely no lung point. That could also be the possibility we saw on the X-ray, that the pneumothorax was quite large. So that is one of the pitfalls indeed. If you have a complete pneumothorax, even though you follow and you sweep backwards, that you might not find the lung point because there isn't one. Most of the cases you do have, but sometimes you don't, like maybe in this baby. So I'm not sure it's a question of the probe, although of course, technically speaking, it's extremely difficult to use such a large probe on such a tiny baby. So you won't be able to do exactly what you want to do just for technical reasons. But I think you did a very, very good job. You made the diagnosis. And according to at least the adult guidelines, we're supposed to find the lung point before we confirm the diagnosis of pneumothorax. But in a severely desaturating or decompensating patient, like pre-cardiac arrest or cardiac arrest, this is more than enough to make the diagnosis and needle aspirate or, treat a patient with a suspected pneumothorax. So I really like this scan, and I'm looking forward to seeing the images after the needle aspiration. So thank you, Dr. Kate.
Thank you.
I don't know, did I ask you questions? I mean, I found them to be very interesting as questions, and I think that you will have, you can be able, like you've shown in this slide, to answer them on your own, but I would really suggest that you continue to try the different settings you have on your sonar scanner. Sonar scanner is a very good machine for lung, but of course, with a big probe, it's a bit difficult in small babies, but I know you can do it. You're almost there.
Thank you.
Okay.
Lovely. Thank you, Kirti. What I'm going to do is I'm going to get Mayank to share his screen, please. So Mayank's screen is visible. That's great. Fantastic. Could we just make sure you're audible, Mayank? You're definitely unmuted, but I can't hear you.
Am I audible now?
Yeah, now you're audible. Beautiful. Beautiful for turning
Okay.
Bluetooth on. Go for it. Floor is yours.
Okay, thank you. So I'll be showing 3 cases. I'll be just quick about the cases. So this was a baby born at 32 weeks with a birth weight of 1.97 with immune hydrops, RHS immunization. And the baby was born by emergency LSCS. The baby had received early rescue surfactant for RDS via LISA. And baby had also received 3 times double volume exchange therapy for RHS immunization, which was basically for rising bilirubin levels. And baby also had culture positive sepsis on day 6. The baby was on SIMV mode of ventilation with 16/6 pressures and FiO2 hovering around 25 to 35%. The spontaneous rate was 50 to 60 and there were no retractions. However, the baby was very difficult to wean off from ventilator. That's why I wanted to do this lung ultrasound examination, which was done on day 10 of life with linear L25 probe at 9.5 hertz. Posterior zones were not imaged. So these are my images from the left lung. So if I go from L1 to L4, so in the L1 region, what I can see is I feel that there's a region of a shred sign, which I can appreciate, though it's not too clear. The rest of the pleural line is well demarcated and sliding well. There are few lung rockets as well as P lines, and there's compact P lines in the upper zone. So I felt that this was shred sign and a patch of consolidation, and along with B lines. The rest of the lung fields appear to be normal, and we can easily appreciate the lung sliding as well as the A line profiles, which are predominant in all the regions. The L4 is basically, I think, this stomach shadow which is creeping in the lower part. So if I move to the right lung, the R1 region appears to be normal. This pleura is sliding well. There's A line profile. There's lung rockets, which is not raising any of the A lines. Similarly, R2 as well as yes, in R3 and R4, what I can appreciate is in the R3 region, this an area. I feel that this is an area of consolidation. Because I feel that these are dynamic bronchograms. I'm not sure if I'm correct or not, but I feel that these are dynamic bronchograms, and this is an area of consolidation. And if I move to the R4 area, this I think I've lost contact in the upper part. But what I can say here is there's a big area of consolidation, and I feel that this is Schresch sign again, and there's a big consolidation in the R4 region. So coming to the X-ray, which was done around the same time. So my interpretation on lung ultrasound is there's consolidation in the left upper anterior and right lateral areas. And this is the chest X-ray, which was available at that time. I'm sorry about the exposure, but what I can appreciate is there's some infiltrates over the right. There's some mediastinal shift to the right. This some infiltrates over the right middle zone, and this perihilar infiltrates as well as infiltrates in the left upper part of the lung. So combining both these radiological investigations, X-ray as well as ultrasound, I feel that these are mnemonic consolidations, and which is more predominant on the right areas more than the left areas. So this was about the first case.
So I will invite Nadya. Just a few questions for me, Mayank, that are very important. So your baby was supine, right?
Right.
Okay, I'm just curious. I mean, like especially because you have evidence of consolidation on your images, doing the posterior imaging is very, very important in such situations.
Oh.
So was the baby unstable?
Not particularly. The baby was on FiO2 of 25 to 35, but I didn't want to disturb the baby.
I get it. No problems. Absolutely fine. That's fair. So I'll invite Nadya in.
Thank you very much for this introduction and the presentation of the case. I must agree with Alok though, on the fact that we do need some information about the posterior lung areas, and we do not, of course, want to disturb the baby. So I'm a bit curious about how you usually scan the posterior areas in supine babies. Are you having difficulties with that without disturbing the baby too much?
Yeah, usually our babies are supine and on non-invasive respiratory support in most of the babies. So they would be on CPAP, and it would be very difficult to make the baby either too much lateral or prone for imaging the posterior zones. So yeah, we face some difficulty.
Yeah, I agree. You should not turn the baby specifically either laterally or prone the babies just to do the scan. But I would encourage you to try and work around that. You can scan the posterior wall. I mean, sometimes it's difficult to do it with a vertical scan. Sometimes you have to do like a horizontal transcostal scan. You have to, try and practice and see how you can do that without disturbing the baby that much. Usually what you could do this is relatively stable baby, right? So you don't need to, I don't know if you can see me, you just take the arm a little bit like this, which gives you access below the shoulder blade, and then you can slide the probe in that you will use. You can actually press down on the underlying mattress or bed or whatever the baby's lying on, and you might not get a complete sweep of the posterior areas, but you will definitely be able to appreciate whether or not you have consolidations. I completely agree with Alok that in a supine baby, where you are suspecting consolidation, you need to scan the posterior areas. This is not a freshly born baby, so this is a baby where the posterior areas are of huge interest. So I think that is missing. However, looking at the very nice scans that you showed us, the very, very nice quality, in L1, yeah, I agree with you. We have the impression, although we can't see it that well in the clip you said, that there is a consolidation hidden over there with a shred sign. But I'm not quite sure because it's a bit dark there, and it would have been very interesting to have a few more, complementary clips over there to really appreciate the consolidation, which is something I would encourage you to do. You don't need to show us everything, but for your practice, that you really check out that zone. You do several scans, you can do complementary, just to confirm, because sometimes they're really small and you're not sure. Sometimes you're sure it's easier, but it's really to construct in your brain a more 3D image of what we're seeing, because we're only looking at the screen, but what we want to get at in the end with all these exercises and stuff is that automatically we get a 3D construction in our brains. So I agree with you. I would suspect consolidation, but it's a bit difficult to see, be sure from that scan, but you've done it, so you know. L2 looks good, I agree. L3 looks good. L4, and I'm wondering, is that the diaphragm that's coming into view, or
yes,
where
I
are we?
feel that
It is.
Yes.
Okay. Could we move on to the right lung, please? Anyway, what we can say for the first lung is that we have probably one area of consolidation. The pleural line is regular. We don't have any patches of B lines. We don't have any infusions, which are other signs of pneumonia, right? And then you have a very nice. Are we still on the right lung? But there's the heart there. There's the left, right? Yeah.
The right.
Yeah. We are on the left. We're on the right. We're on the left.
I showed the first on the left lung, and this is the right lung.
It's interesting that you have the heart there. Okay, so this is the right lung.
There was mediastinal shift toward the right on the X-ray.
So you were saying R1 looked fairly good. I would agree. The pleural line is smooth, regular. We don't see any changes, although just at the intersection, we could ask a question about the pleural line there, but it's not large. R2 looks good. We have the heart. And this is where it becomes tricky to understand where we are. In R3, you were suspecting consolidation. And the question is, are these dynamic bronchograms? Could you tell me where the diaphragm is in relation to R3, what you're calling R3, R4?
So R3, this area, I feel that this is the heart shadow, which I can appreciate because I saw the whole scan. So I know this is for sure this heart shadow. This area is probably the area of consolidation.
So this consolidation then, the question was, these bright spots, are they dynamic or are they static? And that is not always easy. First of all, what we're seeing are bright spots. For me, that looks more like static bronchograms. I might be wrong, but from this clip at least, what we're calling dynamic bronchograms is movement from, outwards towards the periphery somehow. There is communication, if you want. It's difficult to say from this clip, but this is real life. It is difficult in the newborn sometimes, actually, to see the difference. In adult, I'm sure you've talked with Dr. Locke on this. There is robust evidence to say that if you have dynamic, then it's most probably pneumonia or something infectious. In the newborn, it's not that clear cut, especially since this is not a spontaneously breathing baby, right? He's on some kind of pressure support. So I would agree that this is probably consolidation. The bronchograms don't look dynamic, but I mean, in this clip at least. And then going to R4, I'm having a bit of problems understanding what we're seeing. Could you explain, for example, what we're seeing?
So this, on the lower part, we can see there's the liver shadow which is coming in.
So where is the diaphragm then? Excuse me. Where is the diaphragm?
I feel it should be in between these two parts.
Yeah, so this is where it makes it tricky for somebody like me who's not doing the scan. I'm using the diaphragm as an anatomical landmark. And if I can't see it, I'm lost. Although you've clearly said it's R4, I'm not able to get an idea on what we're seeing, because the question was, what are we seeing? If we don't know, if we can't identify the structures we're supposed to see, it becomes trickier. So I would suggest that you always have, when you're going downwards, always have your diaphragm, because that helps limit. It might be the liver, but since we can't see the diaphragm, we don't know what we're really looking at. So your conclusion was that you think it might be pneumonia, especially when you look at the chest x-ray. Might be, but my, what can I say? It could quite possibly be with these areas consolidation, unless we find another reason, be something like pneumonia. However, today at least, we don't have sufficient evidence to confirm infection using lung ultrasound alone. So you would need more than just, I would say, chest x-ray or lung ultrasound. You would need some kind of either a microbiological confirmation or, inflammatory parameters, but it could really well be. What's a bit strange is that you only have this consolidation, and around that, you don't have any sub-B lines, you don't have any areas of thickened pleural line, and you don't have any, areas of irregular pleuris and B line. So I don't know, it could be. So if the baby had gone through Klebsiella sepsis, so it could really be that. So. Very nice. Thank you very much.
Okay, thank you. So I'll move on to the next case. So this was a baby who was born at 38 weeks with a birth weight of 1.79 kg, so severe IUGR, and emergency section was performed for AEDF. So the baby had feed intolerance initially, but later developed sepsis, shock, and DIC. The baby was intubated on SIMV mode with 16/6. Again, this almost same kind of settings, and again, this baby was very difficult to wean off ventilator. So this lung ultrasound was performed on day 6 with again the same probe and same settings. So this is the left lung. So what I can appreciate in the L1 region, that this is there's a small part which is consolidated. This is probably consolidation, small consolidation, And I can also appreciate the B lines which are seen in the L1A area. So this is probably a small consolidation along with the B profile. There's a small the pleura in the upper part appears to be thickened, but and there's also a small defect in the pleural line. I'm not sure what this is, but probably a small again subpleural consolidation. In the L2 region, though this is mostly predominated by the hard shadow, but the areas which I can appreciate is predominated by A lines, and I would definitely call this as A profile. There's lung rockets in between, but this is probably A profile. In the L3 region, I feel that this broken pleural line and probably these appear to be static bronchograms. So I'm a little confused if I should call this consolidation or collapse, but if I had to label this, I would label this as a small part which is collapsed. And in the L4 region, the upper zones appear to be in the L4 region. The upper part appears to be a little dominated by B lines. However, I can appreciate A lines in the lower parts. So in all, I would say there's subpleural consolidation in the L1 and probably collapse in the L3 region. If I move to the right lung, I can again appreciate this. So I would not call this as totally as classify this as shred sign, but I can, because I can see the pleural line in between. So but there's an area of probably consolidation, but I'm not sure if it is consolidation or collapse. Again, there's some area which is definitely abnormal, but there's no shred sign as such. And the rest of the regions of the right lung appears to be normal, the R2, R3, and the R4. These are normal pleural sliding present, and A lines are beautifully seen. So in the R4 region, we can appreciate this is a part of the liver. But the R1 has probably, I'm not sure if it is collapse or consolidation, but on X-ray, so what I can see there, this infiltrates in the right upper area, as well as there are infiltrates in the left lateral, left middle, and basically in the almost we can see the infiltrates over the left region. So again, combining both the investigations, I would classify these as pneumonic consolidations, and which is more predominant on the left upper part rather than right upper anterior. So I can go back. Yes.
That's very interesting as compared to the case before, right? This is more convincing, isn't it? It's not just one or two small areas with a normal looking lung everywhere else. I think you've really nicely shown the fact that by scanning the whole lung, you can find multiple areas with consolidation or collapse. Actually, I would not be that worried about making the difference between both in these small images, because it's really difficult and it won't probably change your diagnosis that much. Who knows, maybe in the coming years we'll say what I'm saying is completely wrong, but for now this is it. Going back to L1, I agree with you. There seems to be a consolidation, at least in, actually there's a tiny one in the first intercostal space over here, yeah. And then we have a larger one, but it's difficult to see how large it is, because with the breathing pattern, at least what we're seeing, we're moving on to areas of thick B lines, and then we go back and see the consolidation. Difficult to appreciate how large it is, but there is something ongoing. In L2, we've got the heart, so we're not seeing anything major, difficult to see. But then again, L3, I'm a bit unsure whether the image looks like that because of the way the probe is being held, but we know it's a tricky area, right? So I would definitely agree with you that we have a consolidation, and you've got multiple bronchograms with these tiny white, not spots really, tiny lines. But again, I'm a bit unsure whether the difficulty we're seeing in really being able to see this consolidation crisply is because of the way the probe is being held, because it looks a bit different than the L2 and L4, for example. But I agree with you, this looks like consolidation, and you've also got some sub-B lines. So these are B lines starting beneath the consolidation that do confirm a consolidation. And then L4, we have like the smaller one, and the first intercostal space going from the left of the screen, with this sub-B line, right? You've got the B line starting right underneath this consolidation. So multiple areas with larger or small consolidation. And if you move over to the right lung, you were saying in R1 that you didn't see the shred sign, but I think you do have the shred sign though, right?
Okay.
It's very irregular. Yeah, I would just call it that. And inside, we could even argue that there might be a few tiny bronchograms. In the other intercostal space, the one that we see a bit more during one phase of the breathing cycle, I agree with you that the pleural line is irregular, and you've got these thick B lines going on. What I would really suggest you do when you have areas like this with consolidation is that you do a complementary scan with a horizontal/transcostal, because you get the ribs away, and then you really get to evaluate your consolidation, have an idea of how far it goes, if you have these bronchograms you're looking for. And it's also very interesting if you measure, because you can follow up and see how your management is changing. R2 looks basically normal, R3 looks basically normal, and R4, congratulations, you've got the diaphragm, yay. So this looks good. Totally agree with you that this looks normal. So what we really have then is what you said. We've got bilateral multiple consolidations of different sizes, with or without tiny static, I would say, bronchograms. I know some people are trying to look at whether there is an interest to applying Doppler measurements to consolidation/atelectasis in babies. For now, there is no conclusive evidence. Is it because we're not doing it right? Is it because we don't have enough data? Is it because it's not interesting in that patient population? I don't have the answer right now. And I think it would be very interesting if we together could maybe do that kind of work to see. So your conclusion was? Pneumonia, probably. And again, this looks much more convincing than the baby before, right? Because it's more, but then the baby before was maybe recovering from something, right? Had already undergone sepsis and so forth. And again, I would never base my diagnosis on pneumonia, only on lung ultrasound, simply because we don't know enough about neonatal pneumonia today. I would think it was that. But I would not start treatment only on the lung ultrasound or chest x-ray aspects. You've got the clinical presentation, and I would probably have some inflammatory parameters. I don't know what your local protocol is, but this is a very interesting cases. Thank you very much.
Thank you. So I have a small case for the last one. So this baby was born at 27 weeks, 920 grams through spontaneous vaginal delivery. So there was risk factor PPROM. Initially, we gave the diagnosis as RDS, and the baby was on CPAP with the settings of pressures of 6 and a FiO2 of 40. So in our unit, we usually give surfactant above a threshold of 30%. So the baby had a rate of 40 to 50 with there were retractions and grunting, and we do not usually routinely get chest x-ray before surfactant. If the baby meets the FiO2 requirement, we usually go ahead with the surfactant. So the lung ultrasound was done before the surfactant could be given. So I tried to use the Bratz method for the same. So in the right lung, what I can appreciate in the R1 region, this is almost alveolo-interstitial pattern, and I feel that if this is present in all the regions, I would call this as white lung appearance. So I feel that R1 is almost a score of 2. Again, same goes for the R2, but in R2, for a tiny bit of time, I feel that there's A lines in between. So I do not know if this is 1 or 2, but by looking at most of the times, I would classify as 2. And R3 is clearly a score of 2, because I can see this fuzzy pleural line, this sliding well. However, this is compact coalescent or coalescent B lines, which is present in all the rib spaces. So this is score 2. And moving on to the left lung. So though L1 and L2 are again a little bit dominated by the harsh shadow, but what I can appreciate is again this subpleural consolidation. In fact, I would say this is more than subpleural consolidation. This is a bigger consolidation, which I can appreciate. This shred sign as well as compact B lines. Again, I would classify this as white lung appearance, because I can see in all the three L1, L2, and L3 regions. I would give this a score of 3. I was a little confused in L2, because what I see this consolidation, this is again a larger consolidation than Mayer's subpleural consolidations, but this is again the same part of L1. So I can appreciate this consolidation is actually coming in the L2. So I did not want, I felt that I should not score this as 3 again, because I have already scored 3 for the L1. So I felt that I should score this as 2, and again L3 I would score as 2. So total score was coming to be 13, which is well above the cutoff of 8. So this was my interpretation, and these were my confusions actually in L1 and L2 reasons, and there was slight confusion in R2 reason, if those were if I should score this as 1 or 2.
Thank you very much. I have some questions for you. Are you using the same settings as for the other babies?
Yes. The depth is 4 centimeters, and the 9.5 hertz is the frequency.
9.4 hertz is the
9.5.
But the other ones were 25. I don't understand.
No. The name of the probe is L25. The name of the probe is L25, but the frequency it caters is between 6 to 13 hertz. So there are 3 modes on this probe. So I can use a gen mode, which is a balance between the highest frequency and the lowest frequency, which is basically average of 6 plus 13 by 2, that would be 9.5. Then if I use the pen mode, which is penetration, the probe switches to 6 hertz. And if I go for rest mode, which is highest resolution, it switches to 13 hertz. So I can choose between.
You were at 9 there, right?
Yeah. I was at a 10.
I really think it was easier to see your other scans. I think you need to use, I totally agree with Alok. I saw he texted here. Use the highest frequency. You were the small baby here. The images in the other ones were much clearer. This is fuzzy. I mean, we can see everything you see is correct, and I totally agree with you. But I think you're making this difficult. Because if you have the possibility, there is no reason such a tiny 900-gram baby to go for general or penetration. This is not interesting. It could be a 4-kilogram baby if you want to. But 900-gram, please take the highest frequency. And also recheck your presets, because it's difficult. I mean, we can see there is sliding and it's a white lung, I agree, but we've lost the crispiness of, I forget, crispness, not the crispiness, of the image, the things we saw in your earlier scans. And you've lost in image quality here. Also, if you look at R3, you could change your depth, because at some point you even lose, you see the rib shadows, they kind of stops, and we're going so much further down. So I would encourage you to change your depth, play around with your settings, and always use the highest frequency. I don't know if you have on this machine focus points or not, but we're losing so much information, and it's all there. So going back to your question, R1, is this a score of a 2? Well, first of all, I totally agree with you with your diagnosis of severe RDS. I totally agree with you that in spite of the difficulties I'm encountering in order to be able to see the images correctly, that the pleural lung seems irregular. It's speckled with tiny, tiny, tiny microconsolidations. It is thick. And again, I totally agree with you. We have the slight lung appearance, which is the multiple B lines and no A lines here. I would definitely score this a 2. Coming back to R2, I agree with you here also. And I can say once in a while you have a little A line that you can see, but it's usually erased by the B lines. And again, the whole point of BRAD scoring system or any scoring system, I mean, we're not in adults now where we have a score going up to, I don't know, 3 zillion. What we want to do is to be able to get a global overview of the loss of aeration. So we need to, again, reconstruct in our minds a global overview. And yes, we can see some A lines once in a while, but generally it's only B lines. So I would feel very confident giving a 2 here. And it comes with a 3. I mean, here, but you can see you've got a lot of attenuation here. The image quality is different, but it's for sure a 2. So for me, that would be for that lung. I mean, no, anyway, for these 3, that would be 2 and 2 and 2, definitely. Going on to the other lung, I'm a bit confused. I will start off with L3, which would definitely be a score of 2. But then I'm just wondering, are you scanning the lung? Where are you? I don't understand where we are. You've got the heart on top. Where is your bad sign?
Yeah, I can see the ribs, but I cannot. I could not appreciate the bad sign in this.
Okay.
But
Let me be really clear. If you cannot see the bat, it is not the lung. You're not scanning the lung. You're much further down. This is probably somewhere around the diaphragm or something like this. At least it's below the heart. So if you were to look, of course, you cannot see what I'm showing you. Sorry about that. But where do you could you put the pointer to your ribs?
Ribs.
Okay, this is where you need to have your pleural line. If it is not there, you are not scanning the lung. So your question was, is this consolidation? Should I score this a 2 or a 3 in L2? You cannot score anything because this is not the lung. Okay? So this is the main point. It can look like the lung, and that's quite normal because the artifacts we see on lung ultrasound are just, again, simple artifacts that are the reflection of the ratio of air and fluid in the lung. But if you were to scan the intestines, you would have the B lines. They're called ring down effects. Or you would have A lines when you have lots of gas. It's just, you know, simple artifacts. But in the lung, we call them A lines and B lines and so forth. So L1 and L2 are not scans of the lung. So the heart is very tricky to get rid of in the scans. Luckily, we have a heart. Babies need both hearts and lungs. But you need to position your probe differently. So it's not possible to get an idea of the lung in L1 and L2 because it's not the lung. And L3 is a score of a 2. I agree with you. So I will go back and rescan these areas. Yeah.
Okay, sure.
If you do not have the bad sign, this is not the lung for whatever reason that is.
Okay. Thank you.
You're welcome.
That was fantastic. Now, what we're going to do is we have Shankar and Sarah. So I was just wondering, Shankar, are you in a position to share your slides, or are we still?
Yes, I am.
Okay, that's beautiful, Shankar. Shankar, if you would like to go for it, thank you so much. That's really kind. Shankar, if you could just introduce yourself, I'd be really grateful. God bless you.
Thank you. Can you see my screen? Hello?
Yes, I can. That's beautiful.
Yeah.
Thank you so much.
Thank you. And thanks for giving me this opportunity, and it's an excellent course. I'm enjoying it. And so I'm just going to, I think I'm aware of time as well, so I'll quickly whiz through what I've got. So I'm a neonatal consultant at Watford General Hospital. It's a level 2 unit in the Greater London area. And I'm also a pediatrician with expertise in cardiology, so I have some scanning experience, but lung ultrasound is completely new to me. So this case I'm presenting is a 32-weeker. Mom came in spontaneous labor, had 1 dose of steroids, but she was having some signs of sepsis, so they had to go for a cesarean section quite urgently. Baby was born in reasonable condition, had deferred cord clamping for 1 minute, and had a delivery room PEEP, but started having grunting soon after birth. Put on CPAP, PEEP started from time 0 almost, was on minimal settings, and had a normal perfusion and normal capillary blood gas. And I got to see this baby around 3 hours of age, and the lung ultrasound was done at 3 hours. The baby was in a prone position at that time. The machine used was a Vivid IQ GE, the hockey stick probe on a lung preset, but I adjusted it frequency to the maximum possible there, 16, and at a depth of 3 centimeters. I think just on reflection, I could have had 4 centimeters here. So this is the baby was prone, so it started at the back first. So on the left-hand side of the screen, you see the.
I'm really sorry, Sankar. I'm just seeing your screen, yes, but I'm seeing a list of files. I'm not seeing any scans. Is that normal?
I think, Shankar, you need to just, your PowerPoint is actually on the lower screen. So if you just click on the PowerPoint will come up, and then you have to go into PowerPoint mode. Yeah, beautiful. So we can see your PowerPoints now at the bottom. So if you just click on your PowerPoints.
Can you see the PowerPoint now?
So now if you click on the PowerPoint you want to show us, yep. No, we still can't see it.
Okay, I'll stop and reshare.
Yeah, no problems. So what you'll have to do is, I think you're sharing one of 5 files that are open. So if you close any files that you can close and just keep the PowerPoints open and then share the PowerPoint. Beautiful. So if you just go back to your first slide, because I think we were listening to the history, and then, yeah. You can start again. We have no problems.
You can see now?
Yes. Yeah.
Fantastic. Sorry about that.
No.
So on the history-wise, it was this is the equipment I used. It's a 32-weeker category 2 cesarean section. A mum came in labor with some signs of sepsis. Hockey stick probe preset, lung 16 megahertz frequency set at a depth of 3 centimeters. And baby was on prone position, as I said, so started scanning from the back first. So on the left-hand side is R5 and R6. I can clearly see the pleural sliding. There is an alveolar and interstitial pattern with predominantly B lines on R5 with some comet tails and almost near compact B lines coming through. On the R6, it's more of an AA profile. On the left side, L5, again, a combination of A and B profile. It's a little bit sort of interesting to see that on the upper part of the lung, more of a B profile, and on the lower part, A profile, almost with a double lung point there. And on the L6, it was predominantly A lines with good pleural sliding. Then moving on to the I turned the baby to supine, and these are the R1, R2, and a combined R3 and R4. So in the R1, again, the pleural line, I thought the pleural line was good sliding there, but the pleural line was quite thick, and there is A lines in the upper part, A profile, and in the lower part of the R1, more of a compact B line coming. And then R2, there was some again, combined A and B profile with good pleural sliding. And on the axilla, R3 and R4 had pleural sliding and A profile. On the left anterior, so L1, pleural line, like the R1, was a little bit thicker, I felt, and there is comet tails and A lines, and I wondered whether there were some small areas of subpleural consolidations around here and here as well on the L2, and the heart was coming in between. And on the L3, L4, it was predominantly a compact B profile. So with the clinical history and the ultrasound scanning, we could say that this baby has a mild to moderate degree of RDS, and there is some that spectrum between TTN and RDS in a preterm. And just for my sake, I just put the M mode as well to see the seashore sign. And this was the chest X-ray. Yeah, so that was the first case, and this baby recovered very quickly. Like by day 2, was off CPAP and was self-ventilating. Yeah.
Fantastic, Chandra. Can I just ask, with your initial scans, was your baby prone?
Yes.
Okay,
yeah.
which is why
started
you
off...
see well-aerated posterior regions. But I'm going to hand over to Nadya for further comments, please.
Yeah, thank you, Dr. Sankar. Thank you, Alok. That would be my question too. Very nicely presented. And yeah, we have a fairly well aerated lung, right? This is the general impression we get. And now we know that the baby was prone. It makes more sense to see the way that we have the distribution of the B lines, right? I have a question for you regarding your lung presets, because I have the impression in some of the scans, they're really small, but in where we can see the lungs a bit better, a bit larger, I have the impression it's a bit smoothed out. So I was wondering whether you sometimes have problems being able to assess lung sliding when it is maybe not, when there's a baby that's small with not with a rather shallow breath. In these clips, we can see really fairly well. I agree with you. We have a very nice pleural line, except for maybe in one intercostal space I can't really see, yeah, this one. But that's normal, right? Where you have the B lines, the B lines start from the pleural line. So it's normal that the pleural line is a bit fuzzy where they start. That's where they start. If we could move on to the next slide. This is where I have my question. Here, I have the impression, two questions for you. Is this the best image you could get of the pleural line? Because it doesn't seem regular, but I'm just wondering whether it's just a question of positioning. Because I'm sure you agree that assessment of the pleural line is a dynamic examination where we're always moving our probe to get an overview. We're sweeping around it. This is in my head. We're trying to get a global assessment also of the pleural line, as you are doing here. But I was wondering if this is the sharpest you were able to get on this baby. Which might have been a very vigorous baby, and it might have been difficult.
The baby started moving by then. I had just moved the baby from prone to supine as well, and possibly I think the scanning plane was not as perpendicular. I think it was slightly going towards the axilla. I think, yeah.
That would be my impression. Yeah, it would possibly benefit from being a bit more perpendicular. But my other question would be, actually my suggestion would be to see if you could play a little around with your presets, because it seems to be very, I don't really know which word would be the best to describe here, but it's
too dark.
No, when it comes to your gain and all this seems fine. I'm just thinking about the lung sliding, and the whole image is a bit, the word escapes me, my apologies, but I think you might have some aspects of your settings, your filters maybe are not perfect because they looked a bit muted, which is, I know, very strange to use for lung ultrasound. But what I want to say is that your preset is probably not ideal for lung. Although you can see lung sliding here, I would think that possibly in other situations, it might be a bit difficult to see. But here we can see it sliding everywhere. But if you look to, I would imagine the R341, possibly if we didn't have these tiny little artifacts, they might possibly at some point be a bit difficult to assess. Which they are not here. I mean, I think everybody agrees that we have very nice lung sliding. But that would be my suggestion if you want to work a little bit more and tweak your settings.
Just a question I have about the clip length. I think the clip length it's set for 3 seconds. Mm-hmm. Is that a good enough time, or?
Well, that would depend for these kinds of scans. I don't know, it's a lot of things, but I would think now you're showing us, well aerated lung with areas of B lines, and that would be enough. However, if you're showing something else, you might want to move to 5 or 6 seconds, right? But for what we're looking at now, this does show us everything. So I would say generally 3 seconds would be okay, unless you're going for something specific, you're scanning a big consolidation, or you have pneumothorax, or, something a bit more, needs a little bit more time to have global overview. So R1 probably not as perpendicular as you would want to be. R2 is better. R3, 4 is very good. Just the question regarding whether you can get the presets to be a little bit less that you have filtered. And then you had one more slide, I think.
Yeah.
Yes. Because this is, again, the L1 is the same kind of impression I have. We can see it, but I think we can see even better with just some fine tuning, and same with L2. Difficult with the heart, of course. But overall, this seems to be a very nicely aerated lung, and I totally agree with Alok. You've just put the baby supine and the baby that was prone, so it's totally normal to have it going there. So I would agree that this were on the wet lung spectrum, more TTN. I would not think there were any signs of IDS. The pleural line is generally nice, except for the areas where we have the B lines, which is normal, of course. So this is this totally. I mean, this is concordant with the clinical history, so that's always nice. Well done.
Thank you. There was one more question I had about the depth. I had set it at 3 centimeters because it's a preterm baby. I'm not sure whether that's sort of good enough, or should I go like 4 centimeters?
You don't need to go deeper than that. You could even try and make it a bit less. You can see. The only reason, I mean, the only thing that's really interesting is the pleural line, because you pick the artifacts, the rest is just artifacts, unless you have consolidation. I would say that would be or something else. I mean, consolidation atelectasis or something that's non-aerated there. That would be interesting to go deeper to be able to assess the depth, the size. Same with diffusion, for example. But other than that, if you're just looking at A lines, B lines, I wouldn't even go as far as 3 centimeters, because it's just the same information. Your main area of interest is the pleural line. So if you have focal points, you can adjust, put them on the pleural line. If you want to zoom in or, blow up your picture, it's the pleural line you're looking for. All this information below the pleural line is, I mean, as long as you can see your B lines going down, you don't need to see how far they go down, right? So my answer would be 3 centimeters is more than enough. You probably don't need that much.
Thank you. Alok, is that okay if I present the second case?
Yes.
Okay, thank you. You can still see the my slide. Yeah, thank you. So this is a term baby, 39-weeker. Mum came in spontaneous labor, had a normal intrapartum observations, but just before birth there was thick meconium. Baby came out in good condition and cried with the normal abgars, but started having distress at 10 minutes of age. I think initially they started skin to skin and breastfeeding, and then the peds team were called back because the baby was blue and started grunting and became floppy. So the team attended and saw quite significant respiratory distress, started oxygen. Very quickly it escalated to 70% oxygen. Initially was on CPAP for about 10 minutes, I think, but if I were to stay at 100%, so the baby was intubated and ventilated, and had surfactant by that time as well. And the scan was done at 2 hours. Same equipment, but a linear, the 12L probe on GE Vivid IQ with a 12 megahertz frequency and a depth varied between 4 to 5 centimeter. So this is R1, R2, and R3 and 4. This baby was very sick, so I just did the anterior and the axilla. So on the R1, I can see the lung sliding, but I saw that the pleural line was slightly sort of interrupted at this point. There was B lines mostly, but I could see some A lines as well. And there were, I think that's rib shadow there, but there are some subpleural consolidations. And I wonder whether this area here is a Shred sign. And then R2, a similar picture, predominant B profile with pleural sliding, but I thought the pleural line was thick, and at times there was little interruptions. And on the R3 and R4, you can see more consolidations, more than subpleural, a bit more extended. And I wonder whether those, there were some bronchograms as well. You could still see a couple of A lines there, but predominantly a B profile. And on the left side, L1, similar to what we saw on the right side. Sorry, the heart was coming in between. The pleural sliding nicely seen. This B lines and comet tails. Some subpleural consolidations, and similar picture on the L2 as well. And you can see the spleen there. And on the L3 and 4, there was more findings in terms of consolidations and dynamic bronchograms with quite significant interruptions to the pleural line. I couldn't be 100% whether I could see the sliding throughout, particularly in the lower part of the scan. But I think at the same time, we put the cold light and transilluminated as well, and there wasn't a pneumothorax. And this was the X-ray, which is quite fluffy shadowing on both sides. Baby's already intubated, and this baby needed nitric oxide and stayed on nitric oxide for 4 days, and then came off and is doing well now. Thank you.
Nadya, go
So
for it.
meconium aspiration syndrome. I actually, it's one of my favorite ultrasound patterns. So the clips are a bit small for me, so I might miss a number of things you talked about. My apologies. I agree with what you were saying. Again, I would look at my settings again, because I think we might, when it comes to your question, are we seeing tiny micro consolidations with these presets? I'm having a bit of a problem being able to answer. I think yes, we do. I'm a bit unsure how many there are, but that's because for me, I'm possibly used to more contrasted images, and I have the impression that there is some kind, again, this, I can't find the word I'm looking for. They're smoothing out, yeah. The image has been smoothed out. So, which makes it more difficult to identify individual artifacts. But having said that, yes, I agree. This is in the first area, we have multiple smaller consolidations. I think, and the reason I think these are the ones is because we have the sub-B lines that start from beneath the consolidation that do confirm the consolidation. Still, we have some variation because we've got the A lines, and I think the scan's probably not perfectly perpendicular, but it's not always easy in a very sick baby. When it comes to the second scan, we have 1, 2, again, yeah, it's very small. So I don't know if these are the possibilities, technical possibilities you have with this probe, where it's possible to maybe only see like increase the, like block the picture and maybe only have maybe 2, 3 intercostal spaces per clip. I'm a bit unsure about that. But in any case, we can see that the pleural line here is irregular. I agree with you. Multiple B lines, but we still have aerated lung. And this is the area where you start having the consolidation. I totally agree. And here we have a sicker looking lung, very regular pleural line, larger consolidations with the sub B lines going down. And we can maybe see that's maybe a bit little of A lines here and there. So if we move on to the next slide, we're seeing the same thing, which is totally what we would expect to see in meconium, right? Areas of non-aerated lung, areas with inflammation B lines and so forth. And going to the last scan where you're asking yourself questions, the L3, L4 one. I think again, maybe you could have played a little with the gain and the contrast. But in any case, this is a very large consolidation. We have at least 3 intercostal spaces, and it's rather deep. We've got bronchograms that, from what we can see on the screen, look mainly static. Again, we're seeing this lung after the baby has received surfactant. So surfactant can add fluid and increase maybe the impression of interstitial syndrome, but I would guess that the conclusion would be this is a very heterogeneous looking lung with areas of consolidation. And your question was, is there lung sliding in L3, L4? I don't know if there's lung sliding or not. Probably not that much on the intercostal spaces with the B lines, yes, where you have the consolidations, maybe a little bit, but there is no reason to think of pneumothorax, is there? It cannot be pneumothorax because you're seeing the B lines and the consolidation. So by definition, it cannot be pneumothorax. You know that we know that pneumothorax can complicate meconium aspiration syndrome, of course, but then you would only see the A lines, and there's not even a single A line here. So I'm not worried about pneumothorax at all, although I'm not sure there is lung sliding in one of the intercostal spaces. But that makes sense in consolidation if the lung is really compact, although this is not pneumonia with fibrin, you know. It's not always easy to really see lung sliding, but you have to look at the pleural line. You cannot look anywhere else. So, but again, the baby was really, really sick, and the lung is not as sick as the baby was. So I'm not surprised the baby needed nitric oxygen, that there was some point of hemodynamic compromise with PPHN. So it's a sick lung, but it's still fairly well aerated for a bad meconium lung. So I think it makes sense to have looked at the heart. So
yeah, so we looked at the heart as well. There was, pulmonary hypertension, the significant tricuspid regurgitation, and a very short pulmonary acceleration time.
Makes sense.
And it's more of hypoxemia rather than parenchymal lung disease. I have a question about the differentiating. So the tips to differentiate between a static and a dynamic bronchogram. So these ones are dynamic.
They're a bit small for me when I'm looking at this. I can't blow them up large on my screen, but for me, when it looks L3, L4, they look rather static.
So I think I have a bigger version of this.
Yeah, my apologies. I need big clips to really look at this.
Is this better?
This is much better. Thank you very much. But it's not running. No, for me, this looks more like static, because although they're kind of jumping up and down, this is not dynamic. Dynamic is when you really have the air going in and out somehow. You have some back and forth movement of the white stuff inside. We're not seeing this. What we're seeing is just, the white areas that are just flashing in and out because of the breathing or the ventilation. Whilst if we did have dynamic, we would have some kind of outwards movement. Alok says he can show us static versus dynamic. I could do that later on also if you want to, on Sunday. So it was on Sunday. But it's not always easy. However, this is not typical dynamic. This is more typical static. However, in meconium aspiration, you could see either. We know these meconium plugs, they plug the lungs, you've got airway collapse, etc. And then they move, so you could have opening up. And nobody has really run a randomized trial on checking whether it is dynamic versus static. So you might have a tiny little dynamic one somewhere over here, but most of these look static to me, which makes sense. I mean, the lung is kind of, plugged, so.
Okay, thank you.
Okay.
Thank you. Thanks, Alok. I'm done 2 cases. Thank you.
Thank you. I'm going to ask Sarah to share her screen. Sarah will be the last person to present today, and I apologize to those who are so keen to present, but I promise we have 3 peer review sessions coming up next week. So please do not feel worried. As you can see in the program, there's quite a long gap now where we will just be going through workshops, practice, and peer review, workshops, practice, and peer review. So the entire intention is that for those who can't actually share scans for reasons that they might not be able to do because their trust might not be able to allow it, we want them to practice as well. And hence I will be sharing scans with you, and you, at least for those who are not presenting, we will be able to get you to critique those scans. So Sarah, go for it. This floor is yours. Sarah, you might have to unmute yourself. We can't hear you. You're unmuted, but we can't hear you for some reason. My gut feeling is your microphone might not be working.
Can you hear me?
I can hear you now. That's beautiful.
Yeah.
That's amazing. Thank you so much.
Okay.
God bless
I'm
you.
sorry because I'm in the hospital computer and I don't know how
Not
to
at all.
use it.
Very
I'm sorry.
visible. Please go ahead and introduce yourself, and we're really grateful. Thank you so much.
Yeah. So I'm from Portugal, and I work in a NICU, a level 3 unit, and we have more or less 2,500 births per year. Okay, so I will be quick because my cases are very simple, and I want to check if I have learned the basics. So I'm sorry for the simple cases. Thank you. So we have, our machine is a Siemens one, and you use the linear probe, and our settings, we have a preset, a lung preset, and we use 10 megahertz for the frequency, and we have 3 centimeters for the depth. So this is a boy with 31 weeks and 3 days when he had born, and he was good, he did well, but he was on CPAP until day 5, and he needed oxygen therapy until day 4. This was my first scan, and I did it on day 6, and he was already breathing well on air, and he was in the supine position. So here is the R1. Sorry, I didn't put there R1 and the R2, and I think in the first one, R2, we can see the pleural line and some high lines and B lines also. Sorry, this computer probably.
They're coming across very nicely, or you just have to click the clips again.
Yeah, but there is, this computer makes me this. It runs 1 time or 2 and then stops, and I don't know how to change it because at home it was a good. It was good. I'm sorry.
No problems at all. We're getting good information.
Yeah, probably if I go back and then, yeah.
Beautiful.
So the pleural line is there. Sharp and lung sliding is present. We see A lines and some B lines, right?
Very nice.
And in the R2, I think we can say the same about the image, some A lines and B lines also. In R3, we have with more detail the A lines present and some B lines, nothing special. And R4, much the same. Yeah.
Beautiful.
And in the left parts, yeah, I could say it's equal or similar, and L2 also. And now I have the L3, and I was a bit confused because in L3 I can see here the pleural line irregular, and I think these are microconsolidations, but I'm in doubt if this is a double lung point here, and I will skip to sorry you to see, but we are on day 6, and I know that TTN doesn't runs with microconsolidations. The pleural line is normal, so I was a bit confused. In L4 we have a B profile more and microconsolidations also. This is the one case. I don't know if you want to talk about it.
Yeah, thank you. I would just say it's very dark because you were asking whether the basics were there. I think they are. You've identified all the main thing, lung sliding, evaluation of the pleural line, but I just find maybe the gain could prove that, because when we look at the ribs, and it's very, very dark from especially the first slide.
Mm-hmm.
I don't know what you discussed with the look, but here I think it would be interesting to see how your changes of gain might change things. But other than that, we can see all the artifacts. I'm going back to what you were saying. So the third slide, you were asking about the consolidation. So for me, micro consolidations are the tiny, tiny consolidations. So this is here. So this is larger than just a tiny micro consolidation. It is a small consolidation, I would agree. And you got the sub B lines, but I don't know why it's there. And I agree with you. This is not typical for TTN.
Yeah. And
double lung point at day 6 is not what you would expect. And besides this, I'm not sure it is a double lung point, but then again, I don't know. Yes. So I agree with you. There is an aspect of consolidation, which is not typical. It has been seen in more severe cases of the wet line spectrum. So it might be that, or maybe infection, or maybe nothing, just, a baby who has an area that's not well aerated. But I would definitely follow that baby up to see how it goes. I'm not pretty sure what it means, but I totally agree with you.
Okay, thank you. So the next case is a girl, and she was a term baby with a suspicion of Beckwith-Wiedemann syndrome, and she was born, and after birth, she developed some signs of respiratory distress with tachypnea and need for oxygen. And my thought was that could be a delayed transition or a TTN. So I did the ultrasound on hour 3, and the baby was supine. So this is R1. Yeah, and in R1, I think the image I see on the left side of the screen is the TMOS, right? Yeah. We can see A lines. Sorry, in the first image, the focus is too low, but then I put it right. So the pleural line seems blurred, but it was sharp then. We have the A lines and we have some B lines, yeah, but nothing special. So I could call it an AB profile. In R3, I think I can say the same, and R4, yeah, much the same.
Can I ask you a question, Sarah? Sorry
Yes.
to interrupt. In R3, in the lowest, at least the intercostal space that's on the right of the screen, I have the impression you have a consolidation there. Could you
I
run the clip again?
Yeah.
Here, there's a consolidation, isn't there? Not this one, the intercostal space to the right of that on the screen. The yes one.
There, here.
Yeah, isn't that a consolidation?
Oh, yeah, I didn't see it.
I don't know what you others think.
Yes. But this baby, yeah, it could be, but the baby at 4 hours of life, she was in breathing well and no oxygen, and did very nicely. So clinically, she had a good outcome. I'm sorry, I can yeah, try to show it there, no?
Yeah, for me, that is a consolidation.
Okay.
So it's interesting.
Yeah, I would agree. That looks like a consolidation. Yeah.
Yeah, probably.
And it just goes to show, I think the more we are to be scanning the babies, the more we will discover things, and we will need to interpret what that really means as compared to what has been defined. Maybe we'll need to redefine some of the findings.
Yeah.
So I think that's very interesting. This for me is a consolidation, but the baby did well. So clinically, there was no, I mean, the finding did not really change the clinical diagnosis nor the management, but it's there. So it's interesting. And I think you have more than one consolidation. You have the smaller consolidations in the other intercostal spaces too. So in this lung, you have at least 3 consolidations.
Completely, yeah.
You agree, Alok? Yeah.
Absolutely, yeah.
Yeah. And Sarah, if I may, because you were asking about the basics, I think you have very nice scans. But again, possibly I'm a bit too rigid when it comes to that. I think you should also try tweaking your settings, because they're making it difficult to see things. Although your scan, technically, you're placing the probe right, you have nice images. It's a question of how the black and white or the grayscale is. So I think try and see if this is something that's easy for you to interpret. Go ahead, do not change.
Yeah.
But you might be able to get even better value if you tweak your settings a bit. See how that works for you.
Yeah.
But in any case, yeah, sorry.
Yeah, these were the first, and then I'll try to improve. Yeah. This is R1, L1, L2, and again, I think we have a sharp line with this A lines and some B lines, and nothing to worry. I think here in L3, I don't know now if here, no, I think it's normal, right?
Yeah. Yeah, I think so. This is some delayed fluid resorption. And I think that sometimes we just see like smaller consolidations, and we say that the baby has probably, you know, like you have meconium has probably some aspiration of some fluid. I don't know if it's true or not, but this is how we interpret it. So it would be interesting to see. There's a little bit of aspiration of just clear amniotic fluid, or a little bit tainted amniotic fluid without really having meconium aspiration. So maybe that's why we're seeing these consolidations.
Yeah.
Yeah, possibly. But anyway, clinically, they seem to disappear. In my experience, when you find these kind of consolidations, it's just a sign, that there's been some aspiration, but nothing, clinically relevant, really.
Thank you very much. So this is another case. This is an extreme preemie, but I did the ultrasound only in day 61 because she was born in December, and when I did it because it was well. She was well in spontaneous breathing on air, but in this day she became tachypneic, and we have to put some oxygen, and I was curious, and I did the scan, and I think I can see here again. I think the gain is not so good, and I think this pleural line is a little bit thick, and we have A lines and B lines. So an AB profile. R2, we have the same. R3, yeah, I think it's R3 and 4, yeah. And in the left lung, we have a better lung, I think, because we have the pleural line thick, lung sliding, always A lines and less B lines, I think. And here, yeah, in the inferior part, I think this is the diaphragm, right? Right, no, here.
I don't think this is the diaphragm. I think it's
Explain.
this is a linear probe. This is the last intercostal space. This is the lateral scan. So this is the diaphragm would come in. Again, I'm showing you on my screen, which is not very helpful. But yeah, it will be coming in here. So I'm not pretty sure if we can distinguish with that well. This is not all the diaphragm. This is probably I don't know if this is left or right, but left. Maybe this is part of the spleen already.
Yeah. Okay.
With the stomach underneath. So the diaphragm is I'm not seeing it that well right there. But you would expect to have it, yeah, where you have your pointer for sure.
Yeah. Okay. So I don't know if I can call it an evolving bronchopulmonary dysplasia.
I think at 2 months of life, if you had a baby with dysplasia, you would have a much worse looking lung than that. Yeah. Going back to your first question, is this pleural line thickened? I don't know what to answer you, because I think the settings are not helping, because we're seeing all the start of the B lines, because there are multiple B lines for sure. This is not completely normal, but it's a good looking lung for a preterm baby. And I think I totally agree that this lung is much better than the first lung we saw. But my question would be, if you could go back to your first slide, please, Sarah. Yeah, so it might be thickened or it might not be. I don't know, because we're seeing all the tiny little artifacts, and it will give this thickened aspect. So it might be, but it seems to be rather, I mean, it's regular as compared to what I would expect in a real BPD baby. Although of course there are multiple B lines everywhere which give this thickened aspect. So it is probably a bit thick, but I don't know how thick. And I would again try to adjust the settings and see if it makes any difference. But there is a difference with the other side. So I would agree that the right lung is more interstitial than the left lung. Yeah. However, globally, the lung seems to be okay aerated. There are no areas of consolidation. There are no huge irregularities of the pleural line. So if it is evolving BPD, it is a very mild form anyway.
Okay, thank you.
I think we'll find out at 36 weeks, I guess, but yeah.
So, yeah, and this is
Sarah, I was gonna say, just because we're touching 3:30, what we can get you to do is get you to present the remaining cases maybe on Sunday with me. Is that okay?
I'm on duty again, but I will try. Okay.
Okay, that's really fantastic.
Thank you very much.
Just while Nadya's getting to set up, what I was going to say is we're going to move to Nadya's presentation, which is going to cover the use of lung ultrasound in congenital diaphragmatic hernia. I'm also sending you an email around for the next few sessions and peer review. So from our perspective, I think what we will be doing is giving you a feel of moving into workshops now. And I will explain on Sunday when I start the session how we actually do workshops, but I'm going to hand over to Nadya.
Thank you very much. Sorry, Dr. Sarah, you were going to present pulmonary sequestration and then I would have nothing to say, you know. So I think you saved me there. Thanks. So I'm very happy to be here again. It's a real pleasure to be sharing and learning together. Thank you again to Alok for this opportunity that I really appreciate. It's always a pleasure to work with Alok, who also likewise is somebody I admire very much, who has taught me a lot. So this is really a pleasure for me. So Alok asked me to talk about congenital diaphragmatic hernia, and I decided I would try to be a little more ambitious and cover a little bit more about congenital lung malformations, but you will quickly see why. It's because, you know, we really don't know that much about them. So, however, I am convinced that we can use lung ultrasound in our management, possibly diagnosis, but I'm sure that it can be very useful in the future. We all agree that congenital lung malformations is something that is relatively rare, but together as a disease group, these conditions may lead to considerable mortality and morbidity in the newborn. Of course, prognosis depends on the kind and the size and the degree of functional impairment. And probably there are very many children out there in the world who are smaller lesions who are completely asymptomatic and undiagnosed. So depending on which care setting we're working in, we might or might not have access to antenatal diagnosis. For example, where I'm working, most of congenital lung malformations are picked up antenatally. So the question of whether we can use lung ultrasound to diagnose that has any clinical significance, I imagine is completely different than if I were working in a setting where there was little access to quality antenatal care and antenatal scans, and where the fact that you need to be very specific on where you would address babies with respiratory distress to specialist centers will come into play. So we have different kinds of lung malformations, right? And from an ultrasound perspective, I think we could look at different groups. It could be situations where we have a lung underdevelopment. I mean, as a rough term, we could have CPAM, formerly CCAM, so, or we could have pulmonary sequestration, and I would leave that to Dr. Sarah. Or hybrid cases. And of course, we've got other things like congenital lobar emphysema, bronchogenic cysts, and so forth, which are largely known in antenatal ultrasound, very little in postnatal ultrasound. So we could start off with saying what little we know about lung underdevelopment, meaning cases where we either have complete absence of lung parenchyma, bronchus, and pulmonary vasculature, or we have milder forms as aplasia, hypoplasia, but we could also have cases of lung hypoplasia as, for example, a complication to congenital diaphragmatic hernia, which is the topic of this talk. I'd like to share with you a case, though, that we had on pulmonary agenesis. And as you can see from the chest X-ray, one of very few who will see coming from me, we can see the typical signs. This was antenatal diagnosis, a term baby who did well at birth, but had mild respiratory distress, and which is why she was admitted in the NICU, and I was able to scan her. And we can see that on the right side, the lung is, white with mediastinal shift, and we've got aerated lung on the left. And this was complete agenesis, and as you can see here from the little echo, oh, sorry about that, going back, there's just a little bit of fluid, and we have no lung on the right side, just this mediastinal shift on the right with no lung. Whilst on the left side, we have, as you can see here, 3 intercostal spaces, lung sliding, and a completely normal lung for a baby that's transitioning. And she did really well clinically. Unfortunately, she went on to get a coronavirus infection, but she recovered well. We also, and I'm sharing this picture from a poster that was presented by Valentina Kondo in the launch, I think it was the second launch, showing here a form also of congenital lung hypoplasia, to show you that it is, when the lung is completely non-aerated, quite easy to pick up with a lot of effusion. But the topic of the talk today was congenital diaphragmatic hernia. And I'd like to show you some images of what that might look like. There are no publications except one I will show you. However, there is a lot of clinical experience, and this is what I would like to share with you today. And the question is, how can we use this? Of course, we can make the diagnosis, especially if there has not been antenatal diagnosis. A baby that is not responding to resuscitation measures at birth, or who has severe or at least moderate to severe respiratory distress that is not really explained by something else. This is interesting as a diagnosis, differential diagnosis in this patient population. But in patients where we already have the diagnosis, be it antenatally or postnatal diagnosis, which in my clinical setting is quite rare, although it does happen, it can also, in my opinion, be used as an interesting tool to evaluate indirectly the estimation of the ipsilateral lung volume preoperatively, but also to assess for complications, either after birth, for example, if you have problems with pneumothorax or lung aeration, also in assessing the contralateral lung seeing how either prematurity or other condition might affect that, and then to evaluate the postoperative course. And in these babies, as we all know, it's more complicated than that. It's not just a question of hyperplasia of a lung related to the intrathoracic abdominal organs. It is really an ensemble, right, with also abnormal development of the pulmonary vasculature, with often a very high pulmonary pressures and very complex heart-lung interactions. So going back to the basics, again, we always have to be sure we're scanning the lung. And this applies to any baby, and more specifically, if there is something we do not understand, we have to look for the BAT. We have to look for the BAT sign. And the reason for that is that other structures might mimic the lung. And if we're not being systematic, if we're not systematically checking and using our checklist to be sure, is this the lung, and then going on to evaluate, is there lung sliding, and then move on, we might have a bad surprise. So as you can see, we could have different interpretations of this depending on the time we take. We could imagine, I hope you can see my pointer, that this is rib shadowing, and this is the pleural line, and that possibly there is no lung sliding. Oh, there's no lung sliding, baby's in respiratory distress, only A lines, no B lines. Oh, is this the lung point? Possibly this seems to be sliding. Sticking a needle in here would be unfortunate because this is the colon. I think you would agree with me if you take a step back and we look, this is the rib and this is shadowing. But if we were to see normally the pleural line should be somewhere over here, we're not seeing the BAT. We're seeing something that could look like the lung, but which is not the lung. So this is colon, and what could be taken to be the lung point, since we've talked about lung points, is actually peristalsis. So sticking a needle into the colon would probably not have the desired effect. And I think having taken the time to really assess whether or not we are in fact scanning the lung would give major information. So are we scanning the lung? Second thing is, once we've started to scan the lung to evaluate for lung sliding and then check what we're seeing. This is the only paper that has been published regarding findings in congenital diaphragmatic hernia. It's on lung ultrasound findings, although we're not really discussing the lung. The authors suggest really evaluating the hemidiaphragm. And if you're missing a hemidiaphragm, as they have shown here by the lines, then you should suspect a congenital hernia. If you do find intrathoracic organs that should normally be in the abdomen, you're in for hernia. And they say they have absent lung sliding on the ipsilateral side, which is because you don't have the lung. But in clinical practice, if you go a bit further, often the pictures I'm showing you are mainly of babies that had an antenatal diagnosis. And you can see here on the chest x-ray that these lungs do not look normal, although it's a bit difficult to evaluate what's happening on the left side. When we look at the scan, again, when we try to look for the BAT sign, there is no BAT here. This is a rib over here. And we would expect this to be the pleural line, but it is not. The pleural line is underneath here, probably. And we can see there is something else inserted here. And this is gut, which is then intrathoracic. And again, another scan, a bit more difficult to interpret, but we can see the gut over here. So we're in the presence of abdominal organs, which we're finding in the thoracic cage. And in this case, we can see that there is some lung tissue. The lung has developed itself after all. So we could expect this baby actually to have a good recovery after surgery. If we take the time, we could also see, like in this case, again, the side of left-handed congenital hernia. This is not the pleural line. And you can see that we are in the presence of peristalsis. So this is also gut. But If we really want to be sure, we would start off again with a vertical scan. We're verifying if we can find the bat or not. And then we want to evaluate what we're seeing. Of course, we'll move down, we'll assess the diaphragm and so forth. Could we have lung tissue without bat sign? It depends on which area you're scanning, right? You could have, slide 13. I'm having technical issues, so closing the chat.
So if we can go back to the previous slide, yeah, you told just that there's pleural line below the colon.
I think this is the pleural line because I've scanned the rest of the lung, but the main point of this is that you have the gut. So this is not normal lung. You wouldn't think, for example, this was consolidation. It's not lung at all.
Yeah.
I know in this patient, I think at least, if I remember correctly, this was the lung that was pushed because I've scanned this baby many times, but you couldn't really be sure here unless you have the full overview that I'm not showing you. So you can see areas of the lung without the bat sign, but this is not normal lung in any case. And you would expect the bat to be here. This is not lung, so this is not lung. And you could also have a congenital diaphragmatic hernia with other disease. So here we have this image again with the hernia, with the gut, but you can see here, it looks a bit different here. This looks more like a consolidation with possibly a bronchogram, but it is actually a CCAM, which this baby had bilateral lung congenital malformation. This is the left lung, left anterior. No, sorry, this is a right lateral superior. And using a different kind of scanning sets, these are slides that were lent to me by Virginie Maupetit. So I'm grateful. You've got the heart over here. You've got the liver that's up, meaning that your liver is in the thoracic cage. And this is where you need to be very careful because sometimes you remember you've talked about mirroring. You know that you need to move your probe around to be sure you're not seeing a reflection of the intra-abdominal liver. So you need to be very careful when you're scanning and take your time. And here again, the question is, can we see the lung? Even if we don't have the bat sign, there's no bat sign here, right? But yeah, we can actually see the lung. Strangely enough, that's squeezed in. It's possible, but this is not normal. And again, this is right anterior. Of course, with congenital hernia, often you have mediastinal shifts because of the herniated abdominal organs. And it's, I mean, especially if you're doing echo also, you have to be quite nimble and find out how you can scan. So yes, we can make the diagnosis of congenital hernia using ultrasound. You can assess bilaterally the diaphragm, either as our Italian colleagues have shown you, using the substernal subxiphoid space to assess both hemi diaphragms in the same scan, but you could also do, like you've been showing, scan all the way down to the diaphragm using the linear probe and follow that diaphragm around. If you have a hernia, you would find the defect if it's large. And also by scanning systematically, you would find these organs, be it only gut or if you have liver, depending on the size of your hernia. So what about the postoperative course? Well, before we talk about the postoperative course, like I showed you, you can evaluate the lung tissue that is there on the ipsilateral side. And I've actually found that to be quite amusing. When you have a baby coming in with a hernia, scanning to see whether you can see the lung at all or not. Because sometimes you can't see it because it's such a severe form. I've worked in a reference center where most of our babies came in with moderately severe to severe hernias. These were not your average, hernias that were managed elsewhere. These were babies who often had undergone antenatal plug placements and who were born a bit prematurely and who did not do that well in the beginning. So many of these babies, you were not able to find any lung tissue, or at least maybe a very tiny little sliver. It was always very interesting to compare that to what the surgeons found and then to the postoperative course. Other babies with milder forms might have, like what I showed you, an area where you could identify lung tissue, at least lung sliding, and a more or less well-aerated lung, often very interstitial with multiple B-lines. These babies usually will go on to have a simpler course. And of course, if you have tiny hernias or where you have a doubt whether it's, just your diaphragm coming up, these babies usually do quite well. There are no longitudinal studies. It's something I would like to do if anybody wants to join me. But you can use it to assess the underlying lung volume. How can you tell which is the diaphragm and lung? Ultrasound, you will have topics on this. I don't remember the dates. But the diaphragm is what you will find when you scan systematically your lung going from up to down. This is where you always have to identify your diaphragm. You always have, if you're using linear probe, it looks like kind of railroad tracks. It's double edged, and you will be able to see the movement with respiration. If you're using a phased array, so cardiac probe, it will look like you can actually assess the movement of the hemidiaphragms, and it's easier to go really anteriorly in the subcostal space. But if we're looking laterally, even anterior, lateral, and posterior, you should always go all the way down to identify your diaphragm, check how it's moving and how it's contracting, and whether it's complete or not. And I know Almudena Alonso, I think, will be, or maybe Adel Mohammed will be talking about the diaphragm more in detail. So what about the postoperative course? Well, postoperative course is usually quite interesting to follow up on lung ultrasound. It can give us an idea about how the lung is expanding after repair. And often what you will see immediately after surgery is pneumothorax, which makes sense, right? Because when the surgeons open up, they remove the abdominal organs and they close, they patch, maybe possibly your diaphragm, depending on the size of the defect, you will have air coming in to fill that space. So if you want to practice on pneumothoraces, this is definitely what you should be doing. Like in this baby here, so this was left-sided hernia that was repaired. You can see from the chest x-ray that the diaphragm has been pulled down. And what we can see, and this is fairly common, the pneumothorax can be really large. So what we're seeing here is one intercostal space, and we can't see the ribs over here. This is the heart, and then we have lung sliding over here. It's like a tiny area. What we can see is that the lung is well aerated in this tiny little area. You can see they're sliding in, and the rest, we have a regular pleural line, and we only have A lines. And following up this serially, what we're hoping to see is that the pneumothorax will become smaller and smaller as this air is spontaneously resorbed. And we'll be able to evaluate, first of all, the aeration of the lung, which here looks good, although it's really small. It's well aerated. Other lungs may have a thickened pleural line, multiple B lines, and look much sicker, really. And then following it up every day to see how this lung is expanding in line with the clinical course. And then what you usually can see also is this, that you will often, secondary in the course, have some degree of pleural effusion, like here. So you can appreciate the lung sliding over here, and you can see that there is this space. I'm sorry, the quality here is not optimal, but I think we can agree that there is a moderately sized effusion over here. So why is this interesting? This is interesting because, first of all, you have an idea of how large this pneumothorax is. It would be, I don't know how you're managing your hernias, but it would be, it's not often that we need to needle aspirate a baby with postoperative pneumothorax, because this is usually the norm. But it's important to know whether or not this baby is improving or not. And if your baby is still needing very high ventilation requirements, even if you're trying your best to protect this lung, possibly in some babies, this could be a solution. What's even more important, I would say, is pre-operatively, and this has happened. If you have babies with very bad lungs who go on to, because of either prematurity, underlying lung disease, or your ventilation strategies, to develop pneumothorax in the contralateral lung, you're really not in a good situation, right? You want to do something very quickly because this baby will not be stable for long. But going back to the postoperative course, pneumothorax first, that will progressively decrease, and it will be very interesting to evaluate the degree of lung aeration postoperatively, which can give an idea about how the baby will recover. And then look out for effusion. If there is moderate effusion and the baby continues to respond clinically, we probably just let it go. But in some children, it might be a large effusion that might need to be drained. And again, this is a longer clip showing a baby that has left-sided congenital diaphragmatic hernia, and this is a scan of the left lateral inferior area. And you can see there's pneumothorax, and suddenly we switch the scan, we lose it, sorry about that. But then when we move downwards, we can see that there is some degree of effusion. There is lung sliding, we're happy about that. The lung has expanded. However, we're in the presence of effusion we can see, after all, there's been some diaphragmatic repair, but the diaphragm doesn't look too shabby over here. It's worse over here. So this is a large effusion. And I think this baby went on to need some kind of aspiration. And I'm leaving you, I'm not leaving you, I'm showing you this clip because it's one I like very much, which would be something you could typically see in a postoperative course of a hernia. And I'm wondering if you want to guess what it is. Anybody want to share on the chat? Please feel free. So this is right lateral inferior scan. Nobody wants to guess, or is this just too easy for you guys?
Maybe this is a drain.
Oh, there's no drain here. This baby's actually doing okay.
Could this be a diaphragmatic patch?
It's not.
Oh.
Let's go through this systematically. I know I just threw the question on you. Can you see my pointer? This little hand that's moving?
Yes.
Yeah,
Yes.
Great. Okay, what is this?
Subcutaneous tissue.
I agree. For me, I would say this is subcutaneous tissue, some muscles over here. Okay,
Yeah.
What is this?
It's looking like a pleural line.
It does, doesn't
Pleural.
it?
No sliding. Plural not
No
sliding.
sliding, no sliding. What is this?
There are no A lines. It is looking like an area of collapse.
Anybody agree with that?
No, I think it's an A
No,
line.
there are A line.
No, there is a line. A line.
There's A lines. So we don't all agree whether there's A lines or not, but I think this is A lines. I vote for the A lines.
Absolutely.
I think these are A lines that we can see more or less. Okay. So if this is the pleural line and there's no lung sliding and A lines, at least there are no B lines. Do we agree there are no B lines?
Yes.
Yes.
Okay, we all agree no B lines. Okay, what is this?
Pneumothorax?
But what is,
Is that plural line?
I think that's the pleural line.
Yeah, absolutely. And there's a
We agree it's the pleural line, yeah.
Yeah.
How
B
does that
profile.
look?
irregular, quite.
Irregular, yeah.
Yeah.
No
It's thick and
sliding.
probably.
Yep.
I didn't hear the last comment, I'm sorry.
It's
Did you
not
say sliding or no?
There is
Not
It
sliding.
is or it is not?
There is sliding.
There is sliding.
There
I
is
think
sliding.
there's sliding. I think there's beautiful sliding. Actually, it's kind of jumping up and down. I don't know how I would call this movement, but it's moving. And what's this?
Effusion.
Effusion?
Diffusion. Yeah. So what would we call this part over here, this whole thing over here? This intersection between no sliding and sliding.
A lung point?
Yeah, this is a
Lung point.
Lung point. So what are we seeing?
So is it fluid accumulating after post-operative repair?
Yeah.
To replace
This-
the air in that? Just curious.
Yeah. So this is a hydropneumothorax.
Yeah.
This baby does have pneumothorax. Well done. This baby also has effusion, and the lung point comes in an area where we're seeing the effusion over here, and this is the we can see actually the underlying lung, which isn't normal. This is the This is after hernia repair. So we can see that this is not a normal looking lung, but it is moving, it is sliding. So yeah, this is a postoperative course of a baby that still has some fluid and still has some air in the lung postoperatively, but it's doing generally well. Yeah, agree, Dr. Mayank, hydropneumothorax. So I like this slide a lot, so I like to show it. So what about the contralateral lung? Well, the contralateral lung really has to do its job if this baby is to have a nice clinical course. But it can often be a problem, especially in the babies who are being preterm. So I think that the mean age or of birth in babies having gone for having undergone well, plug placement, so that's temporary tracheal occlusion antenatally, is around 34 weeks. So these babies or these ladies go into labor prematurely because of rupture of membranes, and they present around 34, 35 weeks. And this is one such baby where you can see that this baby does not have normal looking lungs. This baby actually needed a lot of ventilatory support. And the question was, is this hernia much more severe than what we thought? Or what's going on? I mean, we can agree that the chest X-ray is not normal. And this is the trachea, so it's probably deviated. So we would guess, since this is probably some aeration, that this is probably left-sided hernia. But what about the right lung? So again, you know, I'm no expert in chest X-ray. But when I give you the lung ultrasound scans of the right lung, so this is during inspiration, this is during expiration, and I thought there were, yeah, there are clips. What would you think? This is lateral inferior on the right side. How would you interpret that, and how would you manage that patient?
What
Any
we can
comments?
say, yes, what we can say, this is pleural irregular and dynamic bronchogram.
I don't know about the dynamic bronchogram, but it is irregular for sure.
Maybe also consolidation, subpleural consolidation.
No.
No?
Looks bad, doesn't it? Yeah, I agree. You've got lung sliding. This is the lung. There is lung sliding. It's not only completely, but in areas where it's completely consolidated with multiple consolidations, still hasn't completely collapsed, but yeah. And then we'll go back to show you the others. Oh, here we go. Yeah. Oh, this is the only one we see. Any ideas when we look at the chest X-ray, when we look at the other scans? So this is the pleural line over here. In inspiration, this is an expiration. Again, as you can see, there's real deviation of everything. So actually scanning the contralateral lung can be tricky. The heart is over here. Any tentative diagnosis on why the baby subpleural consolidation? Yes, you will never hear me saying subpleural consolidation again, because I was trained by Daniel Lichtenstein and he is so strict. He told me that, Nadya, all consolidations are subpleural. So I will call them micro consolidations. But I know in all the literature, you can see subpleural consolidation, but I want to remain good friends with Daniel Lichtenstein, whom I admire very much. So I will call them micro consolidation. But I do agree. So this is a 34-week-old baby with this kind of lung, needing a lot of ventilatory support and oxygen. Would you want to suggest any particular management?
Surfactant.
Surfactant. So this baby had severe RDS in the normal lung. We can see very regular pleural lung, also pushed by the mediastinum. So there was also this pressure and having difficulties aerating her lung, clearly as a little girl. So agree, there is consolidation over here. So we gave her, exactly compressed by the organs on the other side, definitely. So our management was to give her half a dose of surfactants. So we use surfactants alpha, and our normal dose is 200 milligrams per kg. So she got 100 and it completely changed her clinical course. She did have severe RDS, and the severity of her respiratory distress was not related entirely to the severity of her hernia. So this is where lung ultrasound can become in handy, not only evaluating the degree of pulmonary hyperplasia without getting a real idea of the volumes, but it does give you an idea whether you can see the lung or you cannot see the lung at all when you're ventilating. If you can't see the lung at all, then you really have hypoplastic lungs. But also evaluating the contralateral lung, because this is the lung tissue that's left that will be compressed by the organs, that will be compressed by the mediastinal shift. And that might also be going through some lung disease, like here, RDS, or it could be severe wet lung or so forth, so TTN. So always scan both lungs because you're managing both lungs differently. And then, of course, what you need to be looking for if you're going for the global view is, of course, looking at the heart, because your ventilation strategies will also affect your hemodynamics, which we all know are extremely complicated and very interesting in this patient population. So I will move on to quickly talk about CPAM, which is a huge umbrella diagnosis of cystic lung lesions. There's pulmonary sequestration, and this is where we have systemic blood supply, and sometimes we have hybrid forms. So for pulmonary sequestrations, the radiologists have published a bit on that, but there have been no lung ultrasound publications by radiologists, to my knowledge, on the CPAM, just cystic lung lesions. This is a typical picture of CPAM. The slide was lent to me by Philippe Durand, with whom I worked in Bistature. So we can see 1, 2, 3 ribs, and you can see there's lung sliding. And I think you would agree with me that the first thing that we see are these cystic looking lung lesions. Looks like a consolidation, at least non-aerated lung, but with these multiple cystic lesions of multiple sizes, variable sizes, some may be communicating or not. And this is the only condition in neonatal lung diseases described in lung ultrasound that has described cystic lesions. There are no others. Maybe together we will find some others, but for now, this is the only one in the newborn. So basically what we can say is that when we compare the findings in CPAM with other lung diseases, we have not found any other neonatal lung diseases that present with cystic lesions. So the conclusion could be, if you do have a baby with respiratory distress that you're scanning and you find cystic lesions, you need to rule out CPAM. Although, of course, CPAM can present with other symptoms. I'd like to show you a case series on different forms of CPAM that were confirmed with CT scans. So we agree that most of these babies, they're completely well at birth. They just want to be left alone, but some can need help. And these were babies who were admitted to the NICU because either of respiratory hemodynamic compromise, and who went on to get their CT scan after birth because they needed surgery. So this was a term baby. And this is what the scan showed. We've got 2 intercostal spaces. It looks like consolidation, but we've got these variable cystic lesions that are communicating. And you can see this on the CT scan over here that really correlates well with the lung ultrasound picture. You've got this type with this huge cystic lesion that could be found here in the right lung. And this is a very interesting case of a 25-week-old twin who was born when the CPAM was at its maximal size. And actually, it was non-specific in his case. It just looked like a huge consolidation, which by the time he was old enough to get his CT scan, just showed this, consolidation on the CT scan. And comparing this to the antenatal diagnosis, all these babies were diagnosed antenatally with their corresponding chest x-rays. It's interesting to see that you can make the diagnosis postnatally with lung ultrasounds. What it might mean for clinical purposes is something else. It has been confirmed by other case series, like this one here from Italy, again, showing comparison of lung ultrasound, CT scan, and chest x-rays. And it's very interesting because here the lesions were much smaller when you can see them here on lung ultrasound, which brings me back to what we were saying, some of the first scans we were peer reviewing today. If you find a consolidation that's there and just remains, please follow up. It could be something else. We do not have the experience today with congenital malformations. So if you have a consolidation that does not resolve in a baby who otherwise is doing well, please follow it up, or please do a complementary imaging technique. I mean, I'm not talking here about the preterm baby who has BPD. There is a reason for this consolidation. I'm talking about other things, like this baby here who showed there was a small consolidation with an area B lines well defined and the rest of the lung is okay. And if we do look at the chest x-ray, something is a little bit off here, but I must admit I would have missed that. It's discrete. And you can see here that it's much larger than expected on the CT scan because the area that does touch the surface is rather small. A lot to be learned here. Another, oh, I'm sorry, this does not move. This was a CPAM, but again, you can see this was a baby at pulmonary sequestration that was actually treated before birth. And what we can see here is you have this lesion over here, and this is what looks like a normal looking lung right beside it. And then we can have hybrid lesions, which are a mix of different types. I'll move on here. So I think the conclusion is, what role should lung ultrasound have in the diagnosis and management of congenital lung malformations? I think we need to define that. We have very little published data today, although our experience clinically is increasing. Postnatal diagnosis for pulmonary, for at least the subgroups of pulmonary malformation seems to be possible. Would it be interesting in the context of following up antenatal diagnosis, for example, to address the issue of timing of CT scans and surgery? For example, in some countries, like the country where I'm working, CPAMs, for example, would be children who are systematically operated upon within the first years of life to avoid potential secondary malignant transformation. I'm not sure that's the protocol everywhere. But maybe scanning these babies with lung ultrasound first would be interesting to see what time the timing of the CT scan would be best to avoid multiple CT scans, for example. But the main question for me would be, what about low or limited resource settings, where you don't necessarily have access to antenatal care? What impact could we have here? Could we deduce that if we have a baby coming in with respiratory distress or an infant, and we do a lung ultrasound scan, if we do find images with cystic lesions, I think it could be interesting to see whether it could be of added value to do the scan, then to be able to refer the patient to a center with CT scans and or pediatric surgery. Of course, we would miss all the babies who are asymptomatic, but at least the ones who are presenting with distress or with some signs, these could at least receive adequate care. A question. And for congenital hernias, I believe this is a very interesting tool in a global POCUS approach, because not only can we use lung ultrasound for diagnosis, like I showed you, but I also think we can use it, and this needs to be developed to assess possibly of how the lung is aerating before and after operative care, but also to assess for complications before and after. Before, that could be pneumothorax or like I showed you, other respiratory diseases, for example, in the contralateral lung, and then following up postoperatively to see whether these child would need treatment of pneumothorax, whether it is not, let's say, resolving as expected, or usually more than ever, this is effusion, that there are no complications like chylothorax, for example, secondary to surgery, that appears that it's not just, you know, a benign postoperative effusion, but more a complication related to chylothorax that would need a different management. So thank you very much. And I'd like to thank the people who were so kind to share their slides and clips with me, Philippe Durand, Virginie Maupetit, Valentina, and actually my daughter Amina, who's helped me to make the memes. I haven't showed you all, and I'm happy to take your questions.
That was a fantastic presentation, Nadya. And I think classically, you know, the slide on the hydropneumothorax is such a beautiful slide.
Isn't it though?
Yeah.
I'm so happy to share it with you.
And I think the key take-home message again for me in this is the importance of going through that standard approach to description, which starts right from what you can see superficially, the pleura sliding, the differences in lung zones, and the importance of going through each area in the comprehensive scan, which, you know, I think Nadya taught us when we were in Paris. I have one question, Nadya, and I'll be presenting one of our cases on next week on Wednesday. So I've had a baby recently with an antenatal diagnosis of a right-sided congenital diaphragmatic hernia. And classically, from our perspective, the baby was tube ventilated in birth and had an antenatal kind of course, which surprised us. The baby was in air, you know, right from the start, very good saturations, PO2s, you know, 100+ when we got into the neonatal unit. And a real confusion from my perspective when you looked at the scan was you kind of had a visible liver below what I could define as completely normal lung on that right side, good A profile. And I was really, you know, kind of confused. Is this just eventuation versus a right-sided congenital diaphragmatic hernia? But as is described in the literature, we shouldn't use ultrasound, more fluoroscopy for the diagnosis, which is unavailable to us. But I just wonder, I mean, your experience of scanning them, do you feel there are any features that can help us differentiate?
I see that Dr. Mayanak is also asking the same question, and I think I will add my questions to yours. It is very tricky. I think we need to be very humble. Yep. We've had a couple of cases where I've had at least 2 babies. I have the same course as yours. And in the beginning, one of them, I'm not really sure, was diagnosed as a hernia. We said maybe it could be a ventration, not sure. But it was so complicated. And we have our radiologists in that setting. They are extremely specialized when it comes to the liver also and the diaphragm. So this is really what they do. There is a huge center for liver transplantation and so forth. And they do lots of, you know, interventional radiologists on the liver. So the liver and this is their stuff. And even they had huge problems being able to distinguish. So I think we have to remain in one of the babies. MRI we're not sure. The baby underwent MRI. Fluoroscopy, we're not doing it either. So we're not sure for many days, but the baby's clinical course was exactly as the one you described. The baby was fine. So we ended up saying that, okay, actually we will cancel surgery. Yep. This baby is fine. And we'll really see how it goes from there. And we tried to counsel parents on what would be the signs to look out for clinically and come back. So it's kind of a fuzzy area. Sometimes it's clear cut, but sometimes it is not so easy. The second case, I'm not really sure I'm remembering correctly, but we had the same doubt, but there I think they managed to say, no, this is probably eventration. But I think that we will have cases where it's not that easy, and we have to ask for help. And sometimes we just have to say we're not able to. Classically is exactly what you say, Alok. You should be able to follow the diaphragm and you will see that actually you don't have a defect in your diaphragm. And I think we have to couple that in with the clinical situation. So your clinical case, the one you will present, very interesting to see that one. It reminds me of the baby we had, and the multi-professional team was really having big difficulties being able to distinguish between both. So I don't really know if there is a clear-cut answer to that. I think when you're able to distinguish, you are, but in some cases you just have to give yourself time and just accept that it's difficult. So I totally agree with you. Yeah. Just be very systematic, because if you're not, you might miss some key things. You might be able to miss that little sign that could differentiate, but sometimes in spite of that, you can't. So
Nadya, my second question to that is, for putting a Doppler on the diaphragm to look at movement, and that, because I couldn't. I mean, I just could not get a Doppler, trying to get it even in the kind of subdiaphragmatic view. But I mean, is that something that you've seen or used in those situations? And
I must admit that I think I'm not using the right Doppler settings. I've tried Doppler in different things. I've tried it for sliding. I've tried it for consolidation. I've tried it for this. I think I'm not very good at it. I think I have to look at my settings. So it has been non-conclusive for me, but I think that it might just be a question of how we're doing it. I don't know if you also have access to power Doppler the way the adults are doing it for pleural sliding, but I think maybe, possibly, we might be limited by our settings because we're looking at frequencies that are different. Yep. I mean, an adult, healthy or not so healthy adult, will not be breathing more than 20 times per minute with exactly. A huge, things. We have babies breathing at 60 per minute with tiny, tiny, tiny volumes. Sometimes we're talking about 2-3 milliliters per breath, right?
Yep.
So I think I haven't at least switched over to see the different settings, but I think it's doable. And I think it's a question of being creative enough and trying out things and thinking out of the box, which I have not been able to do. So I hope maybe you guys can help me with that.
No, not at all. Being very humble. Mm-hmm. Do we have any other questions from the audience before?
We have one.
Yep.
Sometimes there's thorax post-surgery. And can we differentiate chylothorax and pleural effusion by? Well, I don't think that you can really distinguish any kind of effusion by ultrasound alone.
I would agree.
You could say, you agree, Alok? Yes, you would probably think if you have a complicated effusion, you've got fibrin, you've got stuff floating around, if you've got pneumonia, you would probably think it's kind of like pus or something, but you cannot be sure. And you would think that something that's really whitish might be blood, and if it's dark, it's not blood, but you never know. So for me, you can never really know. You could suspect saying, yeah, it could be chylothorax or could be this because it looks like this, but I think the only way you can know exactly what it is when you stick the needle in and you see what comes out.
I would completely endorse that, Nadya. And we've been in situations where babies have had drains, and they may have well developed some of those fibrinous areas or areas of loculation because they've had drains, this fibrosis between the pleural surfaces, which then gives you those kind of appearances. And we kind of thought, well, this could be an exudate, but actually when you drain it, what you get is clear, yellow fluid, which is transudate. And really, these are chronic changes because we've ended up putting drains in lots of times. So I completely agree that the only and best way is to stick a needle and analyze the fluid.
I think we have to do that. Sometimes you have a bit of an idea and it makes sense because you're looking at something. So you also have the clinical picture. But maybe when we have probes that go up to 50 megahertz, we could be able to do it. But for now, I would say no. I mean, you might fall into a trap and it's not worth it.
That's really kind. I can't see any other questions. Does anybody have a question? Would they like to come in just before we sign off? We'll give you 5 seconds. That's really kind. I'd like to thank you, Nadya, for what was an exceptional talk. We continue to learn along this journey. And again, we're looking forward to future talks, both from yourself, Almedina and Adele now. I think, hopefully when you join us in about 3 to 4 weeks, we would have made further progress with our colleagues in trying to image optimize. So thank you so much. God bless you. And thank you everyone for your patience.
Thank you everyone for being so interactive. This is a real pleasure. And I'm so proud of you guys. And especially thank you, Alok, for starting this program. It's amazing. So
not at all.
Take care, everyone.
God bless you all.
Thank you. Goodbye.